We now move on to the most awaited part of today's webinar. I have the honor of welcoming Dr. Jagadisha Thirthalli, Professor of Psychiatry, NIMHANS. He is the former head of psychiatric rehabilitation services at NIMHANS and is of interest in community psychiatry and neuromodulation. He will be giving his valuable insights today about the relevance of anxiety disorders in contemporary clinical training and practice. Over to you, sir.
Thank you. Thanks, Manjunath and the team for giving me this opportunity. And I think that I feel privileged to be the first speaker of this series, which is going to be, I'm sure it's going to catch up a lot of attention and to. Well, I await the slides to be projected. I want to tell an anecdote. It must be about 10-15 years back when I called Manjunath and asked him about to explain to me why his email account has ADC in that. So he told me the story behind it. He wanted anxiety disorder clinic to be started some about a decade and a half back. I dreamt of starting an anxiety disorder clinic, and that made into his email. So all of you may know how passionate Manjunath is about anxiety disorder and starting an anxiety disorder clinic. Finally, I think his very long-standing dream has come to some fruition now, and I hope that this clinic will be of immense help to patients as well as students.
Ask if the slides are visible.
Are the slides visible now to everybody? Can somebody say?
Yes, Jagadisha, you need to put it in slideshow format.
It is in slideshow format. I think it is not seen in format.
You can change.
I'll change and see.
Now?
Now it's...
No, it's not in slideshow format.
It's still not, ma'am?
No.
No. Yeah.
Okay. Thank you. Without further delay, I will start off. Yeah. So anxiety disorders is a fairly neglected area. The reason why I say this is, yeah, it's not moving. It is called one of the minor mental illnesses, as opposed to major mental illnesses like schizophrenia, bipolar disorder, etc. And it was recently excluded from the list of conditions considered for certifying disability. So, but when we see this, it is of concern because certain individuals with severe anxiety disorders suffer substantial disability, and for them, the illness is definitely not minor. Both Dr. Gangadhar and Dr. Pratima Murthy highlighted this issue as to how disabling anxiety disorders can be for people to realize their dreams and achieve what they can. So for many people, they are unable to attain their potential because of anxiety. And if you look at the broad definition of what disability is, if a person is unable to achieve what he can achieve due to a health condition, that is called disability. And it is really deplorable that we are unable to call people with anxiety disorders as having a legitimate disability and help them with various facilities that a person with disability can take. I mean, that's a minor issue, but the larger issue that I want to focus is the fact that it is unfair to call persons with severe anxiety disorders to have suffering to be suffering from minor mental illnesses. For them, it's not minor. I'll give some examples of my own practice to make my point. I've been right now seeing 4 doctors. I will be talking about their stories a little, and I have made minor modifications to the stories to conceal their identity. I'm seeing a woman who is pursuing DM in nephrology in Kerala. She suffered from depression about 2 years back. She recovered completely from depression, but now is unable to go back to her work. She prepares well for going back to work and fixes a date on such and such a date, I will go back. Closer to that date, she panics and loses sleep, and she is only relieved when she takes up a decision that she will not go tomorrow, she will go some other day. And till that day comes, she is completely all right. She is relaxes, she is able to enjoy a lot of things, she studies, but she is simply unable to go back to her work. When asked, she says that as the time of going back approaches, she gets palpitations, she gets body ache, she gets headache, she can't sleep, and sometimes she even faints. Let's not forget, she is a doctor. She already has finished her MD in medicine. She knows very well that there is no reason for her, there is no medical reason for her to faint, but she does faint. And I'm seeing a man post MS in orthopedics from Maharashtra. And again, similar story. He developed a fairly minor, life event, following which he couldn't go for work for about a month or so. He had to take leave because of stress. After that stress is gone, but he is unable to go back to work. The moment he thinks about going back and scrubbing and getting ready for facing an OT, he starts having anxiety and he postpones his decision to go back to OT. A man pursuing MD in anesthesia in Telangana and a woman post MD pathology from Rajasthan. Similar stories. The last woman that I am talking about had suffered from schizoaffective disorder. Surprisingly, she came out of schizoaffective disorder with very least amount of residual symptoms. She could crack exams, including NIMHANS entrance exam for psychiatry. She was told not to join psychiatry. She took up MD pathology from a very reputed institute. But after MD, she is unable to go back to work because of anxiety-related problems. As long as she was a student, she could somehow work. The moment it has come to taking up a consultant like a role and a senior residency role where she has to take work from others, she is unable to do that. Again, she panics and she doesn't go for work. So what you can see is that anxiety was not their primary diagnosis, but anxiety is very disabling to all of them. There is complete remission from their primary psychiatric disorder, but they are disabled equally. What is common to all these people is procrastination in joining back to work. All of them say that they prepare to start from day X. They are well till that day, fully functional. They enjoy their life in all spheres. They have severe autonomic arousal, multiple bodily complaints, inability to get ready to go for work for months and years of avoidance. And of course, there is significant discord in their families who see nothing wrong with them otherwise. They all think that he just has to make up his mind. She just has to decide for herself and she will be able to do that. It is as easy for them because they see that this person is completely all right otherwise. The person is watching TV, the person is reading, meeting with friends. Everything is fine, but why is he not able to go back to work? So they are unable to appreciate this fact and they express their anguish, and that only adds to the anxiety of the person who suffers from anxiety. So I think I have made my point very clear that anxiety disorders may look minor, but they are not minor for people who suffer them big time. So a bit about magnitude of the problem in terms of the public health. In the National Mental Health Survey, it's about 2.57%. I'll come to the details of this particular survey in a little more details in a nuanced fashion in 1 or 2 slides. But it is suffice to say that about 2.5 crore people in India right now suffer from anxiety disorders. And looking at the disability due to anxiety disorders, any disability was suffered by about 55% of people who had anxiety disorders. That comes to about 1.35 crores. And severe to extreme disability is suffered by about 20 lakh people across country. So this is the degree of problem that we are talking about today. All these things that I just spoke about was about adults. NMHS covered adults, and these figures are for adults. I have not even counted children and adolescents in whom anxiety disorder perhaps is more prevalent than in adults. So we will have to add almost equal number of sufferers to this list that I just talked about. I want to highlight some contrast from reports from elsewhere. This is the American survey. 12-month prevalence was about 18%. NMHS shows it's about 2.5%. ECA study, which was done about a decade before the National Comorbidity Survey. In this, they did not report 12-month prevalence, but 1-month prevalence was 7.2%. I think if they had seen the 12-month prevalence, the numbers would have been more or less the same. Then comes the World Mental Health Survey. So anxiety disorders was the commonest of all the disorders according to the World Mental Health Survey. Up to about 18% in some countries had problems with anxiety disorders. That is 12-month prevalence here. Very interestingly, what this survey found out was that there was lesser prevalence of almost all psychiatric disorders, particularly anxiety disorders, in less developed countries like in China and some of the African and Asian countries. The World Mental Health Survey in India, the Indian limb of World Mental Health Survey found an anxiety disorder prevalence of about 3.4%. You should keep in mind that the National Mental Health Survey, NMHS, did not include specific phobias and unspecified anxiety disorders. These are two of the commonest among the anxiety disorders. Phobias and unspecified anxiety disorders are common. This was not taken into account. If it is taken into account, the numbers would have been higher. The kind of patients that I described were not part of the NMHS survey. They would not have, NMHS would not have identified the kind of disabling conditions that I spoke about. Then there is lesser prevalence of anxiety disorder in lesser developed countries is poorly understood. We don't know. I don't know whether it is truly less prevalent among the lesser developed countries. Is it a cultural influence that anxiety disorders are not manifest at all or are managed in such a way that they don't come to clinical attention? Is it a threshold issue that we are okay to call people with minor anxiety as not having an illness, whereas in some cultures, even having a minor anxiety can be seen as having a disorder for which there should be professional help. Are there methodological issues? Do we have tools that truly taps into anxiety disorders? So some of these questions are yet to be answered, but suffice it to say that for a country like ours, even 2 to 3% of prevalence of anything which is as disabling as any other conditions is important from a public health perspective. So as I was saying, anxiety is by itself an important problem. But taking that view will not help us in understanding the importance of anxiety in clinical practice. People who suffer from most other psychiatric conditions experience anxiety, but they are not commonly diagnosed as having an anxiety disorder. For example, depression. Particularly if you look at elderly people with depression, anxiety symptoms predominate in a big way. Schizophrenia, the old adage goes, when psychosis goes, neurosis surfaces. Many people with schizophrenia, when they remit from positive symptoms, suffer from various types of so-called neurosis. Anxiety is one important part of it. Bipolar disorders, all of us are aware that anxiety is an important component of bipolar depression, as well as anxiety is an important part of intra-episodic symptoms of people with bipolar disorders. OCRD till recently was considered as anxiety disorders. Now it is considered as a different. I mean, we can discuss about whether it should be part of anxiety disorder spectrum or not. But the fact is that people with OCRD suffer significant anxiety. There is no doubt about that. Personality disorders, particularly cluster C, also suffer significant anxiety. Many of these are not shown as anxiety disorders, so we seem to underestimate the importance of anxiety in clinical practice. Substance use disorders, anxiety plays an important role in both initiation and maintaining and relapse of substance use disorders. Any seasoned professional who has seen people with substance use disorders would agree with me that in a substantial proportion of them, it is the anxiety that needs to be treated, and the substance use can be treated only after the anxiety has been treated. I mean, it's true of depression also, but for today's seminar, I talk about anxiety. And then there are a host of trauma-related syndromes, which are again predominated by anxiety symptoms. A word about mixed anxiety depressive disorder. One of the commonest presentations in primary healthcare and general hospital settings, again, not typically classified as an anxiety disorder, but it's very common. It is commonly encountered, commonly diagnosed and treated, but poorly researched. I have hardly found much research, well-conducted research in this field, mixed anxiety depressive disorder. Now, I'll talk about how persons with anxiety disorders are suffering in silence, the treatment gap. NMHS found a gap of about 85%. World Mental Health Survey, the India part, talked about 88% treatment gap in panic disorder, which is one of the most dramatic expressions of anxiety disorders. Even in there, 88% of people did not receive proper treatment. For GAD, it was 94%, and specific phobias is close to nobody receiving any specific treatment, according to the World Mental Health Survey. Why people don't get treated? There are many barriers. Poor awareness, both among sufferers as well as carers as in doctors. I think many patients reveal anxiety to their doctors, but the doctors are unable to pick up. they're unable to identify anxiety and treat it accordingly. Stigma and shame about discussing psychological issues with the doctors is again prevalent. It is hard for the patients to find some time to talk to the doctors. And if within that time, if the person expresses anxiety, I don't think many of the doctors will be able to listen to that and manage that. And many a times patients feel invalidated after discussing their anxiety symptoms with doctors, who sometimes brush it off by saying that you're just stressed, you just have to learn to, ignore these things, etc. And they may give them some vitamins, sometimes they may give some antidepressants and send them. Psychological therapy is nearly non-existent for most patients with anxiety disorders. And almost all guidelines suggest that psychological therapies are the first line of treatment for anxiety disorders. And if patients do not get that, they may get disillusioned and they may stay away from treatment. I will share a few of my own experience of working in a community setup in Belur as part of the program NAMAN that we are running in Belur. I have conducted personally few in-depth interviews with non-treatment seeking population. So these are people who have been suffering from anxiety disorders, or what we may call as common mental disorders, and are living with it without seeking any treatment. When I speak to them, what I hear is years of suffering, compromised quality of life, and disability. They did not know that it could be discussed with doctors. They felt shameful or stigmatized to discuss their issues with the doctors. And they also got poor relief from other helping sources. They would have received, they would have sought treatment from, some temples, sometimes some mosques or churches, or they would have gone to some local healers. Many patients that I spoke to had received poor relief from these kind of approaches, and they were encouraged only by patients who received treatment and who have improved. Such people could influence these individuals to go for treatment. And some of the patients that I spoke to have gone to psychiatrists or doctors who are trained in psychiatry, and and also a multidisciplinary team of clinical psychologists and social work team has been there, and with their inputs, they are experiencing good improvement and quality of life. So availability of psychotropic medications is critical. Many doctors, especially primary care doctors, though they want to treat patients, they may not have immediate availability of psychotropic medications. Psychological aspects of validation, most importantly, active listening, education regarding symptoms, and simple measures to relieve anxiety. I cannot overemphasize these aspects, but they should be available with all doctors. Continuity of care may be the key to successful treatment. Many patients with anxiety disorders, if they are put on medicines, they may experience significant relief, or with one or two sessions of psychotherapy, they become better. But they immediately drop out of treatment, and then they suffer from repeated relapses of anxiety, and that they may fail to achieve good remission. I will end my session with a few words for the anxiety disorder clinic. The way forward would be the anxiety disorder clinic should for systematic approach to treating anxiety disorders at NIMHANS to begin with. It should work with other disciplines to address psychosocial aspects. It should study the practice of treatment of anxiety disorders by other doctors, including primary care doctors, and bring about workable solutions which the other doctors, including primary care doctors and other specialists like physicians, surgeons, orthopedicians, pediatricians, how all of these people can identify and treat anxiety I don't think that all patients with anxiety disorders should be seen by psychiatrists. And I think it is best that they don't come to psychiatrists. The reason is that one of the important barriers to seek treatment is stigma. They are okay to discuss their problems with their own general physicians or doctors. Let them feel free, but we should empower the doctors to treat anxiety in an opportunistic screening modality. And if they don't improve, of course, they can refer to mental health professionals, including psychiatrists. And I expect that the anxiety disorder clinic will accumulate sound database for systematic research in this field. I end my talk with best wishes to the clinic. All the best.
Thank you very much, sir. And we have 2 questions chat box. Please send your questions if you are in the chat box. And sir, what two questions are there, sir? One question, I think. Can people with anxiety disorder pursue MD psychiatry as branch?
Of course, yes. Resounding yes.
Yeah. Then Dr. Somshekhar Bijjala said, sir, anxiety disorder identification and management can be done in primary care settings. However, despite the success of DMHP, there exists a huge treatment gap in this area for various reasons.
Yeah, I think it is not just true of anxiety disorders, it's true of almost all psychiatric disorders. I think we have been quoting this as a problem for far too many years. Now, I think we need to find solutions. A systematic approach in trying to understand the primary healthcare system itself will be helpful, because if we have been talking to primary healthcare physicians about anxiety disorder, I think if you talk to neurologists, if they talk about epilepsy being treated in primary healthcare centers, they will come up with similar problems. If you talk about any other dermatologists expecting primary care physicians to do that, they also come up with similar problems. Of course, psychiatric problems may be slightly qualitatively different, and that's why may be different because of the exposure of doctors to in their MBBS career, etc., is poor. But we should also know that there is a significant what we call as demand side barriers. Demand side barriers are people who suffer, who do not approach treatment, for treatment. So we need to address this issue both from the demand side and supply side approaches.
The third question, Rajendra Sharma. Dr. Rajendra Sharma asked, primary physician can start basic medicine. Please name the medicine.
Antidepressants.
Specific name, sir.
Sertraline, escitalopram.
Yeah. The next.
Fluoxetine.
Yes. Next question is, sir, how we can increase awareness?
I just wanted to say that just like psychiatrists, we prescribe omeprazole, famotidine, amlodipine, metformin. So for us, they are not specialist medicines. For us, it is medicine that any doctor can use. All physicians should treat antidepressants as famotidines or omeprazoles of their
essential drug list is not meant for specialized.
Yes.
It is meant for all MBBS doctors, which is
yes.
of India publishes every year. So next question, sir. I think Dr. Mahendra Singh has sent. Sir, how we can increase awareness among other department about anxiety disorders?
Yeah, good question. I think I'm not an expert in this. So I'll try to.
Probably the question meant is something like maybe he's working in general hospital psychiatry.
Yes.
General hospital where he want to convey, educate about anxiety disorder among other department where they can approach.
Correct. I see the point, but again, I'm not an expert in this field, so I'll give my opinion that I can make without being an expert, which is I believe that a few successful cases will open up everybody's eyes. So I'm sure doctors in other branches of medicine would be seeing patients with anxiety disorders without doubt. If we are able to work with them and help them to identify anxiety and treat and show that it is A, easy to treat, B, helpful to treat. And treatment of anxiety helps in the management of their general medical condition as well. Then I think we have done it.
Yes.
Giving lectures may not help. Showing on ground with real patients and showing that it is relatively less time consuming and effective, that approach may help. Manjunath, you are an expert. You can add.
Sir.
Yeah.
See, among all anxiety disorders are not same. This is a strength for us to educate other medical professionals. For example, it is very easy to educate other doctors about generalized anxiety disorder and panic disorder, because these two anxiety disorders among all anxiety disorder will approach to other physicians. For example, panic attacks, any patient who comes with panic attack, let them do whatever they are doing. Those who are not improving, you ask them to send to you. One, or else you can say that if you are friend with him, you just call me when that patient comes, I will come and talk to you. That is a one other approach. Coming to generalized anxiety disorder will not, majority of the time they don't go with the anxiety symptoms to the patient as a presenting complaint. They may go with the sleep disturbances or gastric problems. So those kind of patient, use a respective specialist. If you talk to them, I am sure even cardiologist knows that which kind of patients are anxiety. They don't know what to do. So if you just liaison with them, either initially you can go and sit with them or ask them to send it to you and give the feedback to them. That is how you can increase the awareness among the other professionals and increase your credibility and in the general hospital setting. So this is the next question, sir. Does diaphragmatic breathing exercise help reduce anxiety?
Yes. It is one of the several methods that we can use to reduce anxiety, particularly if it is a panic attack or any acute anxiety attack. Diaphragmatic breathing is very helpful. There is a significant physiological explanation as to how it brings down anxiety, but I'll not go into those details right now.
And Dr. Somshekhar Bijjal has sent message earlier. Thank you. And next said that the PCP model may be easy option. PCP model, I think he might be talking. Somshekhar, can you allow him to talk, sir? Can you just allow him to talk? Dr. Somshekhar Bijjal, what does it mean, Somshekhar?
Actually, sir, good afternoon. Thank you very much, sir. So actually, it's developed by Dr. Manjunath only. Primary care psychiatry model, in which there are simple questions are there, which actually we found out it and we have incorporated the same thing in one of the PG thesis. Student has done it, and still with that also, there used to be significant gap in the treatment of various psychiatric disorders, and more so with the anxiety disorders. But they were very easy to pick up the psychotic disorders, whereas common mental disorders as well as the substance use disorders, these are the two things which can be, which they forget to pick it up when you use this model and went to the PSCs where the DMHP psychiatrists have been trained, trained by the DMHP psychiatrists, all the medical officers. So still there was what defined by Dr. Manjunath was functional treatment gap. So that used to be very high. So then subsequently we trained some more times these people. Then there are few people who were well enough to pick up that model, and they were able to do it. And in fact, I'm happy that few of the IMA doctors, various branches, we subjected to give a training in IMA forums also. So few of them have started using and they felt very helpful, especially the surgeons and especially oncologists and oncosurgeons and some of the physicians. In fact, nowadays they are antidepressants are more used by the neurologist and physician compared to psychiatrists, as I noted after this some of the trainings in the IMA forums. So in this way, this is easy to apply and easy to utilize by, can be used by the primary care physicians. And one more thing, as Jagadisha sir has told, that there are various reasons why people are not picking up in the government setup. There are various reasons, so let us not talk about that. And so, but many things can be.
I think you have lived more as a government doctor,
Yes.
PhD doctor, than as a psychiatrist. You should be able to.
Yes, sir. There are various reasons, but it's very.
Thank you, Dr. Somshekhar.
Sorry for that. Still, we are
No,
unable
no.
to solve.
Thank you. Next question, sir. Is there any way to increase psychological therapy rather than pharmacotherapy, as most clients seeks this? And one of the reasons for stigma is being prescribed drug for long duration.
Yeah, I think, as I said, many guidelines suggest that psychological therapies are the first line therapies. Uh, uh, I think one of the biggest problems in anxiety disorders is that the doctor does not spend enough time with the patient. So, listening to the patient's problems, carefully giving importance to all the symptoms. What are the worries that the patient has about the health? Many of them do not say that I have an anxiety problem, but they will say that I have this health problem or that health problem. So if you're listening to that and educating them that this is what happens during a stressful time, how the body reacts to stress, how the body reacts to challenging situations, will relieve their anxiety to a large extent. And then telling them that, look, you try a few methods of relieving anxiety by yourself, which includes deep breathing and doing pranayama, yoga, leading healthy lifestyle, and a concept that I tell my patients is to have what is called as a worry time. So you don't worry all the time. You keep yourself an hour to worry about things that bother you. And during that time, you can reflect on your challenges and find solutions for yourself instead of worrying about it all the time. So some of these techniques can be very helpful. One of the things that will work when you are challenged with this dilemma of psychological versus pharmacotherapy, when people are not willing for pharmacotherapy, is to encourage them to take up psychological help, either by yourself or referring them to other people who are experts in that, and giving them enough time. If they improve, well and good. If they do not improve, they will come and ask you for medicines. So, I mean, we can allay the fears about medicines. Some of the commonest things about medicines is that it is addictive, it will put me to sleep, it will make me weak, etc., etc. So those are common misconceptions about medications. Having a very open discussion about that, and most importantly, listening to their worries and validating their worries and giving alternative explanations will help.
Next question, sir. Rakesh Chandraj asked, do you think phenomenology of anxiety among person with SMD and primary care would differ? If so, do we need to formulate different approaches in managing them?
It's very fast. Can you repeat?
Okay, sir. Do you think phenomenology of anxiety among persons with SMD and primary care would differ?
Yes.
If so, do we need to formulate different approach in managing?
Yes. I believe that anxiety suffered from people who have recovered from or who are recovering from severe mental illnesses is qualitatively different from anxiety that we see in persons with common mental illness otherwise. So there are fairly fundamental differences. I don't know whether systematic studies are there. Rakesh, you are an expert. You should be able to tell me more about it. But what I have observed in my clinical practice is that persons with severe mental illness who present with anxiety have a different profile, in the sense that they may not be able to explain their anxiety completely. They will say that I don't want to do this, I don't want to go there, I feel fearful, but they will not tell you any cognitive distortions that you see in persons with common mental illnesses. They may have aversions to certain areas where they would have experienced psychotic symptoms, like hallucinations in a school or delusions in a given situation. They may try to avoid such situations very commonly. They may have neurocognitive deficits because of which they will not be able to concentrate on what what bothers them and what strategies they have to adopt. They have social cognition deficits, which may help, which may contribute to social anxiety, unlike people with social phobia otherwise, who may not have significant social cognitive deficits. They have different kind of appraisal of the cognitive situations. So there are some of these fundamental theoretical differences between people who suffer from anxiety disorder in the context of severe mental illness.
Next question, Srinidhi Om Prakash. Even during MD post-graduation period, most centers do not expose PGs to non-pharmacological treatment. How to get more experience in psychotherapy part, which I think is sought by upper socioeconomic strata seeking care in private sector.
Yeah, I think it is important that everybody is trained in some degree of psychotherapy during their post-graduation time. I think the Psychiatry Teachers Association and the movement Dr. Kishore and others head should are doing already, but they should do more work on this to enhance the training of all postgraduates in dealing, in psychological management. Even in some of the premier institutes, I have heard psychotherapy is not taught, or it is taught very, very casually and not with a formal approach. I do think it is high time that we take it up as a serious issue.
Yes, sir. Dr. Shalini Naik has asked one of the some of my MD students who passed out and are in private practice told me, sir, our MD psychiatry curriculum in INA does not teach and train as well in treating anxiety disorder and sexual disorder. Apparently, they make majority of the patient pool in private practice. This webinar series is the need of our for young trainee. It is more of comment, sir.
Yeah.
And next, Dr. Mahendra Singh has asked, up to what extent biofeedback is helpful in anxiety disorder?
I think biofeedback is a evidence-based therapy in managing anxiety disorders. I don't have references to straight away quote, but I am of the opinion that there is good evidence that biofeedback helps in anxiety disorders.
Yes, sir. Last question, sir. With anxiety in Dr. Venkata Suresh, with anxiety now being labeled the modern epidemic, are we truly addressing the root cause or just managing the symptom? Is psychiatry at risk of becoming a band-aid solution rather than transformative force in reshaping mental well-being?
This is an excellent question. I think a psychiatrist's worth his salt would not give any band-aid solution. Band-aid solutions are given by people who may be very busy and they will not be able to. So they may do it in the 1 or 2 instances, but if it doesn't work, any true professional will not do that. There are 2 aspects to this question. One is individual related. If a patient comes with anxiety as a symptom which is related to something larger in the society, etc., the psychiatrist will be able to help that person. But the question also has a dimension that society is changing in such a way that it is making people more vulnerable to develop anxiety. I don't think psychiatrists are or should be working on that front. That is the field of other professionals, including sociologists, anthropologists, and other social engineers, I would say.
Thank you, sir. And probably we are thinking of having one more session in this webinar series, having what are the anxieties are not an anxiety disorder. So maybe in a later point of time, that time we will discuss in lengthy. Otherwise, thank you very much, sir, for your inaugural talk and no more questions. Thanks for giving inaugural talk and encouraging.
Thank you very much for it.
And some of the guidance which you have given, we will keep it in mind when we work on this thing. Thank you very much, sir. I would request Nikita to wind it up. The first inaugural talk.
Thank you so much, Dr. Jagadisha, again for this wonderful talk, an exciting beginning to the webinar series. And we thank everybody who has joined us today.
Once in 2 months.
We thank everybody who has joined us today in the middle of a busy working day and had such a wonderful and enriching discussion. We hope to see all of you and even more people join us for the next webinar, which we will be announcing shortly. So as mentioned earlier, we plan to host this webinar once every 2 months. We will be sending out flyers soon regarding when the next webinar is to be scheduled. We would love to hear your feedback as well. Please send in your comments, feedback, queries to the email ID, which we will be sharing in the chat box. Thank you all for joining us today and have a great day ahead. Thank you.